This is probably one of the coolest cases that I have seen in a while because it has so much to teach. So we're going to take some time on it, and I hope that you enjoy it as much as I did, and I continue to see this. So this is an evolving case, so we will learn together. So the case is very, very severe obstruction, and it's very hard to wake up. Today is May 14, 2024, and welcome to SEVA VentRounds. There's no endorsements of any mode, manufacturer, or company. Whatever we say, it's our opinion. And sorry very much, I'm trying to solve problems for everybody at the same time. Alrighty. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. These are my conflicts of interest. These are the ones from Rob, and Rob is trying to connect. He was also having connection issues, so here we go. Keep your microphone muted. There's CMEs and CRCEs, and I'll put the code for the CMEs when we're done with this. Now, let's start with what you're going to see today. This may help you understand the waveforms. This is a key SEVA knowledge, and what we're showing here is the electrical activity of the diaphragm, this waveform, and it's in millivolts. And this is a technology that was developed by Chris Hinderby, and essentially with it summarizes the full spindle of an EMG into this waveform, and it's on electric and millivolts. And so you have a point in which it starts climbing, which is the start of the activity, and a point where it peaks and then it decays. You then have the esophageal pressure, which is a surrogate for the pleural pressure. And as the muscle starts contracting, the pressure will start dropping inside the thorax. And so you will see that there's a point in which it starts dropping around here. And then finally, you have the airway signal, which you can see some changes on the airway, a drop in the pressure in this case, and then eventually it pressurizes and the breath begins technically. So this is important for you to recognize the waveform for electrical activity of the diaphragm and the esophageal pressure, because you now have technology that will allow you to see that on the ventilators. So this is our first case. And actually, this case, I have several images for you, but let's start by you reading this waveform and start by the tag. And again, this is the full screen from the ventilator, and just pin what you think the mode tag is. And again, as I said, we apologize for the technical issues with you all connecting, but now you're here. And I see that the team is starting to rapidly put the tag that identifies the mode as pressure control, CMB A. And that's there's some clues. There's several clues within here, but the first one is the commercial name on the top, PRVC, and you see a tidal volume, which is the target tidal volume that we enter. All the breaths are mandatory, so continuous mandatory ventilation, and it's a adaptive targeting, meaning that the inspiratory pressure will be adjusted to achieve the target tidal volume. So here you can see that the target tidal volume is 400. The patient got 466, and so the algorithm will adjust between breaths the amount of pressure that it's delivered, so that at the next one it's closer to what it should be. I don't know if Rob is on the line now.
I'm here.
Hey, Roberto. Any comments so far?
Nope.
All righty. The next question for you all is, what is the load for this patient? And I'll ask you to pay attention to the inspiration and expiration. good job. So the team is starting to take a look at this, and it seems to me that the consistent thing that the team is looking at is a resistive load during expiration, and you can rapidly see on this waveform that there's a peak flow and it rapidly decays, and then you have a very long time to reach baseline. Actually, it never reached baseline throughout the expiratory time. So each one of these markers here is a second. So you have 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, and it did not reach baseline. So definitely resistive during expiration. And then some of you wrote during inspiration. So Arsal said, well, during inspiration, I think that there is PMOS. And so I think that you're right, Arsal. If you look at inspiration, and you have two breaths over here, and if you see the flow waveform between the first one and the second one, there's differences on the waveform that you can identify. So that's the first thing. You see that the flow is not the same. It tries to move up. There's still, without a doubt, resistive. It doesn't reach the baseline, but there is evidence that the flow is moving away from the baseline, and they're the same on the second one. So I think that you're correct that this is PMOS. Roberto?
You didn't want to unveil the other signal?
Well, yeah, actually, we can unveil it from now, and I presume you all are looking at this last waveform all the way on the basis. This one that it's in pink, and that's the electrical activity of the diaphragm. You see electrical DI, and it's in microvolts, as we had shown on the prior graph. And that's showing you that there's activity of the diaphragm during those periods of time. And so you see this alteration here. But if you didn't have this one, you would still consider that not perhaps on the first one, it would be maybe this little hump over here may have pushed me to think about it, because I would still think that there's a high resistive. But the second one is definite. There's an evident change on what the waveform looks like. So I would feel more comfortable with the second one saying that this is PMOS. Roberto?
Yep.
Right. But now that you have this ability to monitor with the electrical activity, that helps you. All right, what about the trigger? Is it normal, early, late, false, or failed? All right, I see a couple of answers so far. Well, this is actually makes you smile inside. So I want you to pay attention. This is not NAVA, so this is PRBC. So I want you to pay attention to but we have the NAVA signal that helps you see where the PMOS started. And if we look just at the flow signal, let's start imagining that you don't have the NAVA signal. So I'm going to make this a little bit bigger. And now you can essentially see here how the flow was coming. It was not reaching baseline, and suddenly it starts moving up, right? So you see how there is evidence that the patient is doing an inspiratory effort, and that's just by looking at this. And if you come up and look at the pressure waveform, you will see that the pressure waveform is also decreasing, and the overlay of the estimated pressure based on the NAVA catheter and the NAVA level that we set on the screen, you can see that the electrical activity started here. Now, I will just highlight right now, this ventilator we use a lot. And is this a machine or a patient trigger breath? Yeah, Philippone, this is correct. This is a machine breath. And we know that even though it's synchronous, so the patient activity started, there is no color change. So this is a mandatory breath that synced with the activity of the patient, but it was not the patient triggering the breath. It was not the patient triggering the breath. So this one over here is a breath that is by the luck of chance, a mandatory breath that was not triggered by the machine, that occurred at the same time as the patient was doing effort. The second one, all of you recognized as an early breath, early trigger. So, Rob, comment?
Yeah, it's interesting. It'd be interesting to know if this was set as a flow trigger or a pressure trigger. But either way, you see the patient does make an effort, but it probably doesn't reach the trigger threshold, whatever it is, because it's pretty small, right?
Yeah.
It's really an unusual graph.
It was, and I'll show you a couple more images that will clarify this, but this is one of those situations in which, as I was thinking about the taxonomy, and if you think about PMOS, and now you have the ability to have this breath was triggered by the machine, and yet we have PMOS. So it doesn't fit the early, because actually it was the activity of the patient started before. It is not late. It is not false, because it's machine triggered, and it's not failed because there's actually pressure on top of that. So this is an aberrancy of nature, of the coincidence of the machine triggering at the same time as the ventilator. So if you had to read this without the EDI, I mean, I would have said perhaps I would not even have detected this with my own eyes if this was PMOS. This one definitely, but this one I wouldn't. So this is a new item that I hadn't not thought about as we go through. Rob?
Why couldn't it be normal? Does normal imply patient triggered?
Well, it's not triggered by the patient.
Yeah, but it's triggered by the vent.
Yeah, but it's
Every
luck.
breath is triggered, right?
This is luck. This is absolute
Yeah, it's
luck.
lucky, but why wouldn't you call it normal triggering?
I may call it normal, but this is not a breath that the machine is the patient is triggering. So I could call it normal, but I would put a little asterisk here saying it's luck or whatever. For tweeters, it hit right.
But my question is, does a normal trigger classification require patient triggering?
Well, that's what we have to. I mean, I will not delve that much into it today because we're gonna spend here a long time.
Yeah.
Yeah, but I think that's something that we need to think about, because this is a mandatory breath that is triggered but it's not triggered, and there is evidence of PMOS. So
yeah, but it's synchronous with a patient signal, so it's not asynchronous.
I understand, but this would fall into the early trigger, but it doesn't because it started before.
Mm-hmm.
So if this was, and I'll show you a couple of images. So there's another image that makes it. I have a couple more out there. So just give me a second. Just keep that in your mind, okay?
Okay.
Alrighty. So and then the rest of what happens is just it's a manifestation of the early trigger. So I'm not gonna essentially the cycle doesn't make more sense, but I do want to highlight an item that it's important here. And let's talk a little bit about the expiratory work, or normal. So the first part that I want to highlight about the expiratory is this peak over here. And you can see that there's a rapid component, rapid time constant, there's a low component. And the amount of air that got exhaled here is around 100, because we measured it on this patient. We believe, because this patient was requiring higher pressures, that this is likely all airway and circuit. Rob, any concerns with that?
No, I agree with that completely.
Yeah. And then the long component is definitely expiratory, so high resistance. However, I want you to point out what you see at the beginning of this breath, because I'm going to show you later what actually was happening with this patient. But you see that there's no PMOS, and the PMOS starts much later. Actually, you can see it here. But there's not a peak in the peak is much lower than on the prior one. So in this case, that lower peak pressure that you see here was because this patient actually had active expiratory muscles. So it was, even though I cannot see the expiratory work as usual, but I mean, because there's so much resistance, this patient was contracting her expiratory muscles, and that's why when the breath started, doesn't get as much peak.
Awesome.
Rob?
So EDI doesn't record expiratory effort?
Really
Does not. Does not. And whoever is on the phone, can you mute yourself, please?
The other thing I would say is that the resistance is so high, it looks like it's a partial obstruction of the ET tube or a ball valve or something.
Yeah, all righty. So the next item here is, I'm going to show you the next image. So this kind of shows that a little bit better, Rob.
Yeah.
And so you see here another early trigger. And then you see how the second breath doesn't get any breath delivered, or very little, if anything, 48 cc's. So that was a manifestation of the active expiratory muscles. And once the patient took a breath in, I mean, this was another early trigger. You can see a big breath going into.
Yeah, that shows it very clearly.
Yeah. Another item that I thought that was very interesting on this image, you can see the activation of the adaptive targeting. So you see this pressure is higher, and I'll show you another image where you can see that a little bit better. But when the patient triggers a breath, and I know Ariel had mentioned this too, and several other people have brought this up, the algorithm for PRBC on this machine, when the patient triggers, it uses uses the pressure that it used for the last spontaneous or patient triggered breath, if that makes sense. And you can see that this was a patient triggered breath because it changed to white. So really a different rate. This double trigger is because of that. No, remember that the diaphragm is not an expiratory muscle. It's an inspiratory muscle. So the diaphragm should be relaxed during exhalation. So that's why you don't see it. This is measuring the crew of the diaphragm. And that was to a question about why don't we see the activation of the expiratory muscles. Another important point to see here is the very high EDI on this patient, and this patient has very severe obstructive lung disease long-term, and so she consistently is having very high EDI values. So here's the other one for you guys to see, and so this graph is important for you to recognize. So again, remember, we're looking at PRBC, so PC CMBA. And I want you to notice, as you see the waveform for pressure, you can see that the waveform for pressure starts going up from breath to breath. So do you see that? So this one is at this height, this one is at this height, this one is at this height. So it moves up, and that's part of the algorithm for adaptive targeting. So that's how adaptive targeting looks. So if you see this waveform, without being able to see the PRBC, this would suggest to you that there's an adaptive targeting happening there. Rob?
That's a really excellent illustration. And it also shows how quickly the ventilator responds, right? It doesn't take a bunch of breaths before it starts increasing the pressure.
Yeah. The second part that I want to highlight is the reverse trigger for the patient, or early trigger, and here it becomes very evident, right? So So I'm gonna go all the way up for you to see. So let me amplify this. So if you look at this waveform, you see the peak flow and then evidence of PMOS. The peak flow, evidence of PMOS, peak flow, and then evidence of PMOS. And the evidence of PMOS is because instead of moving downward towards the baseline, it's moving away from the baseline. So that tells you that there's PMOS. And then on this overlay, which we have the NAVA signal, you can see that the peak corresponds to the rapid peak, and then it goes down, and then there's evidence of PMOS. The PMOS starts, and there's the increasing flow. But do observe, and this was something that where I was going with this, is that and this has relevance, I think, when we talk about phenotypes of early trigger and where they occur, that you'll see different timings of that early trigger. You see that how different it occurred on this one. And if I go to our prior example, just for this, just for the sake of observing it, you can see the difference between this one and that one, and this one. So different phenotypes occurring at different times in the same tracing. Makes sense? So I see there about early cycle. Yeah, absolutely. There's going to be early cycle in some of this, but that's a result of your early trigger, without a doubt. So now let's go to our next one, next image. So this patient, we placed the catheter because the goal of the team was to get her to comfort, and so as she was coming out of the level of sedation, now you can see her doing the activity on her own. And this is an important item for you. Remember, this is the estimated pressure at the NAVA level that was set. So the NAVA level that had been set on the screen, that when you press NAVA and you're putting the insertion of the catheter, was 1. And so you can see that this looks very high, and that would be a very high pressure that the patient would receive. But there's a pressure limit at 45 here, so the patient should not get more than 40, and I'll show you how that looks. But exactly, Miguel, excellent eyes. So now you have this patient triggering the PRBC. So now you see those breaths being triggered by the patient. Actually, look at. Let's just amplify this for a second. That's why this is such a good case. So you see the patient activating. So if you were reading this waveform, you would say, well, the activity started here, and the breath triggered down here, and you can see that it triggered a little bit, that there was activation here. You could say it's late, but if you see the electrical activity of the diaphragm, it's even farther back. The next breath, you see evidence of activity of PMOS, so the flow goes towards the baseline, and there's no breath delivered, and you can see the EDI activity here. And actually, just remember that when you cannot see on the flow, you can come and see on the volume. It amplifies it, and you can see there this plateau that tells you that the patient was trying to do a breath. And then you have the next breath, and again, you see, if I was reading this without the EDI, I would read this as, it looks like an okay trigger, maybe a little bit delayed, but not that terrible. But when you overlay the electrical activity of the diaphragm, you realize how delayed the activity was, the pressurization of the ventilator was in relationship to the patient. And then the activity of the patient ended, and the system was still pressurizing the system. Rob?
Was the goal to eventually put this patient on NAVA?
So your orders are my command. So there you go. Yeah. So then eventually we transitioned the patient to NAVA, and we started at a very low NAVA level. We started at 0.1 because of the amount of EDI that the patient had. And then we titrated the level up. You can also see that we limited the pressure. So this patient, because the peak pressure, the pressure limit is set at 45, the patient cannot get more than 40. But with that, it was achieving between 6.5 and 7.5 So yeah, and that's why, Miguel, you see the plateau. The plateau is being caused by us so that the patient doesn't get more pressure after that. So it continues to get it plateaus because it's pressure limited now. And so during that period of time until it cycles off, it's gonna get to that maximum level. So that's why we see that. And absolutely, Ariel, you're correct. I want you to be aware that when you're a NAVA, you set a NAVA triggering level, which you see down here as white. I'm gonna amplify again, so you can see the color change. But it has a whatever happens first. So in this case, if it sees that the pressure dropped to 2 centimeters, which is what it said. And I'm not saying that that's correct. It was what it was. We were looking at the NAVA level and I just captured this image. So you could say, well, Eduardo, why didn't you put flow? It would have worked better. And perhaps you're absolutely right. But that is so that is why this one is white, because it was pressure limited. So sorry, pressure limited, pressure triggered. So the ventilator detected the pressure drop first, and so it used that instead of using the EDI for that breath in particular. So now the patient at this point is breathing 23 breaths per minute, and 6.5, we'll see what the ABG shows for her after we do this, but the goal is comfort and trying to wake her up and get off the device. So I thought, oh, and here is just for your viewing pleasure. Again, no activity, you see the breath, and you see how the ventilator doesn't deliver anything. And I see this relatively often in obstructed patients. And when I see that this image in which you can see the peak pressure was 43, so the ventilator was really pushing pressure in, and the patient didn't get anything. When I see this, you need to uncover the patient to look if there's activation of the expiratory muscles, which was the case here. And so that's the case for all of you. I think that it's an outstanding learning case with many things. So just to recap for all of you, you got to see this issue where we have a synchronous breath by chance. We got to see early trigger and to read it with electrical activity of the diaphragm. You got to see severe obstructive process with activation of the expiratory muscles. You got to see, again, this algorithm of the adaptive targeting and how it changes the pressure throughout. Again, several examples of early trigger in which there was evidence of that they have different timings, and so you may have it occurs very early or it occurs very late. We talked about the electrical activity of the diaphragm and how here we saw a false trigger again. And finally, how when we set it up, we talked about the pressure limit and how it flattens out the NAVA level because we put up a pressure limit on the amount of pressure that it can give to the patient. And finally, how activation of the expiratory muscles will limit how much the ventilator can deliver. So if you see this, look at the belly of the patient because there's probably a lot of expiratory PMOS. With that, here are the CME for the caregivers, CRCE for the RTs. This is available in YouTube, so if you want to review this and you have comments, please send it to us. And here are the resources and prior episodes. Again, we apologize for the technical difficulties. For those that are watching this as a recording, you'll have a little bit of a gag on all the issues, but do review this. There's a lot to learn here. Thank you, everybody. Have a great day.